how is the modern healthcare operating model different today than in the past, and where does AI fit in that world?
Wow, that's a heavy question. Let me take a crack at it. Before that, I would say, Brian, I loved your reference to real AI, and and I thought that was a bit of an oxymoron. I thought it was funny. But when you think about the broader set of trends that are actually shaping healthcare right now, I would classify them into like four major forces, right? So one, I would say, is the economics driven by, like private industry. We've all talked about like, rising premiums, rising costs of healthcare. The government's trying to moderate the cost of expenditure in healthcare. Medicare and Medicaid changes are propelling us in that direction. So there's a lot that's going on, and that employers, combination of employers and government and market forces are shaping that. The second, I would say, is consumerism. So just like mobile phones have been ubiquitous right now, where and when healthcare services are consumed is being consistently challenged and put to test in every market that we are in. What type of service? How is it consumed? Where is it consumed? The third, I would say, is competitive landscape. And I think we've seen this shifting over the past like 15, 18 years. Like, the payers are taking on some provider functions, providers are taking on some payer functions, they're taking financial risk. You see networks, heterogeneous networks forming in different areas, clinically integrated networks, ACOs forming to come together to deliver care. So the traditional model of entities coming together to kind of through acquisition to kind of deliver healthcare is kind of getting challenged in the market. And the fourth is technology. And AI is the latest, but I think even prior to generative AI is the latest. But even prior to the generative AI taking shape, I think the automation in general has been a huge force for change. And you can think of that last one as kind of like a horizontal that disrupts all three of those. So I would say, like, when you think about how healthcare is paid for and the operating models that are changing towards paying just shifting away from paying just by volume to outcomes-based models, or like by service category models, are getting changed. And when you double click into that, the administrative areas are getting widely disrupted. As in the consumerism, how healthcare is consumed, and how healthcare, the availability of a healthcare provider at any given point in time to provide a service, that's being shaped by the readiness of the technology platform that's enabling accessibility of that service, and the ability for the competitive landscape, multiple entities to come together in a single platform that can measure performance for like a list of, for a panel of patients, or that was previously not possible even 10 years ago, is being made possible by technology right now. So I would say the combination of all of these things are creating an operating model that, that are pushing us more naturally into value-based care, and AI is front and center in driving that transition.
Feby, to you now. To drill a little bit further, everyone and their dog is using generative AI. At Memorial Hermann, what are some of the other applications that you're looking at from an operating model perspective? Like, what AI-specific tools actually are effective?
Yeah, and just to sort of talk about the problem that we're actually trying to solve, maybe it's just helpful to sort of put that foundation as we go into the applications.
Sure.
It comes down to some flavors of what Deepak just said. One is reducing total cost of care and helping us transition to value. We do have a lot of risk-bearing instruments within health systems. It's often undermined, but if you think about, we're the largest employer in our market. We've got a whole bunch of Medicare ACO and commercial ACOs in our book of business. We have our own health insurance platform. And in Texas, which is not a Medicaid expansion state, we also take full risk on all the uninsured that use the emergency rooms as their point of care access. And many of them are repeat users. So one big problem is, how do you reshape the total cost of care curve? The second being, how do you sort of continue to expand on the S-curve of quality and outcomes? We've come a long way in terms of, as a society in the US over the last 200 years, life expectancy has gone up by about 40 years. how can we sort of continue on that over the next few years? How do we sort of take up both foundational breakthrough innovations, but also bring a lot of these things to predict who's at risk of disease and how they're progressing, and so that's a big issue that we work on. The third is, of course, productivity. There's always the supply-demand arbitrage in healthcare, 200,000 nurse shortage, and then 100,000 plus on the physician side. We'll never have, in many subspecialties, the time of access runs into weeks and months. So anything that we improve in terms of access and panel size can really be helpful. And that's an important consideration too. And then obviously you'll have to layer in all of this in terms of margin efficiency and financial resilience in terms of the future. So taking all those problems, what we have done is we've bucketed them into clinical, operational, administrative, consumer, and path-breaking foundational workflows. And we've kind of come up with about 36 or so AI sub-themes, and we're going through them in terms of what creates the value, what's ready, where there is less hallucination and readiness to adopt. I'd say so far, a lot of the applications have lent towards the ones that are in the self-driving analogy, more level 2, level 3. So I would say things like ambient listening to improve productivity, improvements for the providers, a lot in revenue cycle for denials management and prior authorization, and improving the productivity of that workflow, but also increasing the yield of that as you go through that. And timelines where accounts receivable are we want to sort of really reshape that and run into a lot less denials. On the clinical side, we are across all of our VBC and platforms trying to really think about predictive risk stratification and sort of going into how do you get the patient early, whether it's for our oncology ones or nephrology ones or even the primary care ones. We have a lot of partnerships with tech-enabled service providers like Wellvana and Guide Health and Monogram and others. And what we're doing is trying to sort of embed these solutions within that, so we're able to get the patient before they show up at an ER or use more of an expensive chassis. So that's another one. And then even within the hospitals, we're exploring all of these things about risk deterioration and stratification, for example, within sepsis, or showing how can we renormalize operations through length of stay optimization or readmission reduction. So bringing the productivity of our assets as well as our humans has been a big emphasis. And the way we are trying to sort of deliver the ROI is not only through, I actually don't think a lot of that value in the near term will come from sort of the staffing side, where a lot of the people talk about, hey, it's all about how do you bring efficiencies, but actually we're finding a lot of those applications we couldn't actually do before, simply because the cost of doing some of these at scale with humans was way too high. And now that we are able to use the generative AI applications, we're able to do we're going to able to touch 100% of our patients now for medication adherence, as an example, which we couldn't in the past. We would just sort of have some type of a predictive risk stratification, and the nurses would just call those people. So now we're able to engage with all of them. So I think the art of the possible in terms of engaging with a broader population and creating an ROI on that basis, which accrues towards more cost savings for the system for total cost of care. And that's why I had to bring those 4 points up front, because you're able to drive the economic value with these applications.
One quick clarification. You said you're now able to reach many more patients than before. What are you using? Like automated nurse calls, AI making the calls?
Yeah, it's these generative AI solutions with partners like Hippocratic and others. We're able to sort of reach to the entire base of our population.
Okay, makes sense. Greg, to you now. You live in the specialty world and very much a fee-for-service world. And you have challenges like prior auth, which everyone does, and also referral management. How can AI address these issues?
Well, I think yesterday one of the panels talked about how we have created all this data in healthcare, but it's really unusable data. And so I think that's where really AI is beneficial, is getting you to the point where we can all speak the same language and query it, really. And so if you think about prior authorizations, really what that is taking all of the patient's information, their medical records, their charts, what's been done, and then cross-matching that with what are the requirements to get the next procedure we're trying to authorize, right? And trying to gather that together for clinicians is very difficult, and then staff that are high school educated, infinitely more difficult. And I think that's where we're seeing a lot of the benefit of technology and AI, is it's able to really distill that out, pull that all together in a very timely fashion. We heard, from 45 minutes to 1 minute from somebody yesterday, and then cross-reference that to an ever-changing requirements from the payers. Just this year, we had January 1st, all of a sudden, one of the payers requires prior authorization for inpatient visits. So we had to cancel a bunch of patients, and then you upload what that is and then reschedule, right? So it's really facilitating and making all of that data a lot easier to then leverage in the different ways you have to. And referrals is similarly the same kind of crazy way. If you think about it, we still fax referrals. That's how we exchange data, which in this era is insane, right? And so hopefully we can work towards a platform where we can actually exchange data, something that is more relevant in the 80s and 90s. And I think that's another area where we're really seeing some of the benefits of AI and really leveraging all this digital data to make it useful.
A few years ago, I heard that in a provider's office, who has the most advanced technology? It's the teenager with the smartphone, because we're still using faxes. Now, Anil is the host. He has given me permission to add some masala in, make things spicy. So, Anil, you get the hardest question. You were once at IBM Watson, which would have us believe that AI solved cancer until it flopped pretty spectacularly. So here was a legacy tech company trying its hand at AI. Now you're at an Innovaccer, which appears to be going gangbusters. I hear an IPO maybe in the offering, but it is also not an AI native company. How do you convince health systems and doctors' practices that your technology is the real AI, is the one they need to improve their operating models?
Well, I think it goes back to what my co-panelists have articulated, which is what is the end state of the operating model we all want? If we simply use AI to scale broken processes, we're not really fixing the problems. I'm just going back to the Watson Health days, and I'm not going to comment here about all the things that went wrong, and it had nothing to do with marketing or our conferences at all. But I think one of the biggest things was there was a belief that if you simply bring data together and you use smart engineers to go look at that data, that you'll find things that other people couldn't find. And I think part of the problem is understanding how healthcare is delivered today and where you want to go. And once you do that, I think you get to a much better ability to sort of take pieces of the process and re-engineer those with AI. Now, what is Innovaccer doing well? So I was at Watson Health for 5.5 years, about 5 years too long, but I got acquired in, so I was an involuntary member of the team. What I think Innovaccer is doing, which is incredibly smart, is we're looking at the actual real-world problems that people have. And Feby alluded to clinical, operational, administrative. Some of the biggest challenges are more on the operational side. So we're tackling some of the thorniest issues that are going to allow us to mature with the customer, create confidence and trust, and allow us to go in a direction that says, okay, let's iterate through this. How do you convert a pilot to a production-ready, scalable offering, and find really smart partners to go do this with? Because if we find the wrong partners, we built a solution for one person, right? So making sure we're partnering with the folks that understand the industry, understand where the industry is going, and then bring smart engineers, bring smart data scientists along for the ride, and make sure we've got high quality data. But I think, as Greg said, just having a bunch of data can still create information overload if we're not careful. So it's not just about the data, it's a deep clinical expertise. And then the other thing I'll just share, and there's a book written on Watson Health, you guys can go buy it. I have nothing to do with it, and don't believe everything you read in it. There's a couple book chapters written, but the one thing that IBM underestimated, and frankly I'm okay with that because they paid us a lot of money for my company, data is hard. Getting data clean is not easy. And so if we're dealing with a company like Innovaccer that has made their mark on really understanding the fundamentals of data, then moving into AI, not easy, but it's a little bit easier than for a company that's simply trying to jump into AI without really understanding the clinical context or the data side.
Well said. Greg, I'm curious about contract negotiations with payers. It used to be that payers were far ahead in terms of adopting AI, and now I think providers are sort of catching up. So do you think that sort of levels the playing field where are you using AI to, boost your arguments on getting better reimbursement or pushing back on denials and things like that?
Yeah, I think where we've seen some benefits with payers particularly is, again, this kind of prior authorization of going back and forth, and you're starting to get in this kind of AI battle where the payers have their own AI agents that are then going after you, and so it's almost like a Terminator for a prior authorization. And so I think that's one of the areas where we're seeing it. Yeah, so we need Arnold, is what we need on our side. But I think in terms of contract negotiation, really helping to glean through the contracts and making sure that it's pulling things out. And realistically, our organization, we're still not to the point where you can really use and leverage those experiences from patients. I think we're getting there, but realistically, it's in infancy. And so from a contract negotiation side, not as much, but I think there is some benefits in terms of just leveraging, again, sifting through all that information, that knowledge, and that data, and figuring out, okay, what is really here? Because we all know in contracts, some people are very, speed of trust up front and tell you what it is, and you can go quick, and others bury a lot of code lines in there and are a little more obscured in what they're trying to accomplish. And I think that's one of the areas where we've seen some benefit is from AI.
I would add to that in the value world, not just in the fee-for-service world, I think AI and at least automation technologies has really created a lot of opportunities on how payers and providers partner with each other, right? I think especially as we look at areas like Medicare Advantage and even managed Medicaid, the successful initiatives are those where that relationship moves from a buyer-seller partner transactional relationship to an operational partnership, where there's a continuous exchange of information and visibility and shared accountability towards taking care of a population. So what that also means is that it's not the negotiations is one part of it, but then there's a continuous assessment using technology on, when you have incomplete data, how do you forecast, trends in utilization? What are the leading indicators you can actually see? How do you use, leading indicators and signals that you see to supplement real data that you have to reach a point where where medical utilization is going to be for one particular month, and combining that with, what your real data is actually telling you, and then making changes accordingly. Things like, when your payer is telling you that there are 100 patients who are attributed to your panel, but when you look in your electronic health record, it's only 90, and there's a discrepancy between the two. And in a multi-payer environment, like that gets really complex really quickly, right? If you really think about the business problems that exist in this administrative and business area in value-based care, the potential for AI to synthesize varying data inputs from multiple endpoints and then automating your response to it is pretty immense.
Thank you. Feby, I'll come to you. You mentioned ambient AI, which is, of course, the golden application that all hospitals are looking at. However, as golden as it is, having happy providers is important. You don't want pissed off, burned out physicians. But it doesn't mean that I'll get ambient AI and now I can see 10 more patients in the day. That's not happening. So you're not seeing ROI, which is why companies like Abridge and all these other companies are getting into rev cycle and getting into prior auth, because that's where the money is. So from your perspective as a technology buyer, what kind of AI actually brings ROI?
Yeah, I think, look, one should think about the cost of doing business over time and say, look, in order to have a productive enterprise of the future, what's the right sort of operating model you need to deliver? And today, or 2 years ago, we would have said, like, this is the amount of labor or staffing required to run a productive franchise of the future. And 100% of that would be driven by humans. What we are saying is that could we 10x that as our system grows and our 10x that intensity, but then replace or 10x that volume, but replace the intensity of that workload and bring the human part of the workload, maybe keep it flat to where it is today, so and then represents 10% of the overall activity, and these are just illustrative numbers, but then 90% of it is coming through technology, because you're reimagining applications, like I was saying earlier, that can then drive a lot of value creation. So, for example, if our risk-bearing instruments can show 100 or 200 basis point improvement simply because I've got more intelligence by engagement not to send the patient to the ER or avoid a surgery, which I therefore then goes into my bottom line. That's pretty phenomenal, number one. Number two, even in the traditional fee-for-service, if we can just keep the alignment, which improves clinical care and outcomes and reduce the leakage and just manage the longitudinal share of care of the patients. Patient shows up at the primary care, uses imaging, uses specialty care, uses the hospital, uses home health, rehab, whatever. All of those assets, how are we tightly integrating and therefore creating a joint package to reduce the total cost of care is much more effective if there is more alignment. And so I really think about share of care as an important component. And of course, the efficiency drivers, like you're able to sort of get into specifically getting the patient more engaged and therefore happy. All of these leads to operational utilization of the assets better, operational utilization of the humans better. And going back to your point, I do think that it is possible. Okay, let's take ambient listening as a specific case. I did not underwrite that based on the more patient visits to the doc, but I did underwrite that seeing that there will be a substantially high patient net promoter score because the patient and the doc are engaging with each other. You mentioned the fact that the providers are very happy. We had lots of vignettes of people that were physicians who were telling us that they're able to spend more time with their kids and so on and so forth. But and then the revenue cycle part of it can obviously just take the business case forward, and that's why all of these companies will move in that direction and are moving in that direction. But long term, I do think strategically, as health system leaders, we would have missed the plot if we're not able to say how we're dramatically accelerating the panel size. Mm-hmm. And today, the panel size of a few hundreds in the case of Medicare, maybe a few thousand in the case of commercial, I would love to see it 10x. And to do that, ambient listening is just going to be one part of the pie. Right. But you'll need to have AI that goes into, I'm not advocating for ChatGPT Health yet, but in some format, can you not take low acuity visits to be complemented with a doc and then route all the really complex one where a doc's insight is needed to the doc? And therefore, a doc can sort of embed some of these AI solutions and therefore dramatically improve productivity. So ambient listening is just one part of the sliver of that whole productivity narrative. But I certainly think that as the population is aging, and we're not going to add that many docs with that same velocity as we did in the last 50 years for a variety of policy reasons and other factors that we read about in the press, technology will be the only way in which we'll sort of cross that supply-demand gap. And we will work on that.
Can I offer an
30
addition to
seconds,
that?
I need to get to Anil. So.
The work that we're doing in Risant Health actually has been a pretty exciting, offered some exciting proof points in this space. On ambient, I would say it's an interesting metric that we measured where, on average, every doctor saves about 20 minutes in actual time, but the perceived savings is north of 2 hours. So there's the satisfaction sometimes exceeds the actual ROI that's on the table. That's one. I'll say the other is that this is one area where Innovaccer actually helps us in this whole area that we're calling value-based care guides, primary care guides. So our ability to access standard clinical evidence using AI for a doc, no matter where they are in a heterogeneous network, in a clinically integrated network, using a common set of content, it's been huge. It's helped move more what we call shift care left, move more care into primary care, and reduce referral to specialists where applicable, so that there's more capacity for specialists to take care of patients who actually need that. So.
Sounds good.
I think one thing I'll say as a provider, and obviously we have employed physicians as well, is I think with the ambient dictation software, it also is creating an alignment with the organization, the provider. And I think all too often, especially with employed physicians, they feel as they're getting pushed around, they don't have control over things. And I think it's a unique opportunity where you can say, no, we're investing in you to help with your lifestyle and your kind of work-life balance, as well as that patient experience. And I think similarly with referrals and everything else, again, if you make authorizations easier, the right patient, the right place, there's nothing more frustrating than having I'm a hand surgeon having a person show up with knee pain in my clinic because they self-scheduled or they got scheduled appropriately, and now they're frustrated, you're frustrated, and so I think again, right patient, right place, as well as really partnering with providers to show, hey, we're helping to help you take care of our patients. I think culturally is very important.
Anil, to you, Epic and Judy have providers sort of wrapped around their little fingers. So the question I have for you is, how important is it for AI tools to be integrated inside the EHR, or can they work outside and work as well?
I'm sorry, who's Epic? No, the
That
reality,
tiny company in Wisconsin.
Yeah, the reality of it is that clinicians are used to their workflow tools, whether it's Epic or any other EHR. And I think it's incredibly important for not just Innovaccer, but for anyone that is thinking about how to improve the life of a clinician or any of the other members of the care team to make sure that it integrates into the future workflow that they should be using, not necessarily the current workflow that may be broken. That's one element of it. I think it's incredibly important also to think about, especially my three co-panelists, as they think about procuring different AI solutions. It shouldn't be like sitting in Times Square or standing in Times Square and someone opening up their code and saying, which watch would you like? And then, it's going to be at the point where we got to get all these different AI systems to be talking to each other in a meaningful way. So it's that orchestration aspect of it as well. If you have the AI orchestration, which obviously Innovaccer is very focused on with our platform, but if you also keep in mind that these systems need to integrate, and we're not at the holy grail of interoperability just yet. So sometimes you have to use Scotch tape and baling wire to make sure that we're not making the system too clunky for the clinicians or for the users. But the final piece of it is to make sure that the entire EHR landscape is evolving. There is increasing movement towards meaningful interoperability. And at the same time, we see lawsuits, and I'm not going to go through all those, you guys can Google those, that are really trying to press what are the edges of being able to have a sort of an internal system that doesn't expose itself to some of the value adds that folks like Innovaccer and others can do. So I think this is going to be a moving target, but absolutely needs to be integrated into the workflow. Just what workflow are we talking about? The broken one today or the new one that we need to evolve to?
I'll stay with you. This is the last question for the panel, and everyone will answer the same question. There are providers out there that are thinking of getting into AI. What advice would you give them? Starting with you, Anil.
I think it's really important to think about AI as not just a story of a point solution in time. This month I'm going to do this pilot, next month I'm going to do that pilot, and I'm going to keep my fingers crossed that by October they can all communicate with each other. So my recommendation would be to find reasonably smart folks who are thinking about what does it look like in a platform approach to orchestrate all these different things. ROI is important, workflow is important, adoption is important, accuracy is important, but I would be, and the Innovaccer folks can close their ears for a moment, I would be more than happy to sacrifice a little bit of accuracy for a significant amount of adoption and integration into the workflow. Whether it's 0.999 accurate or 0.998 is not as important as if I can get 80% of my clinicians to use something versus only 25%.
I think first is velocity. I think sometimes this boil the ocean mentality of like, I want to get it all right, gets you to something which is, delays the implementation. So I think that in many of these use cases, you'll find that, just going with something without having an AI solution is much better than the status quo, and sort of leaning forward to that without boiling the ocean is, so not a lot of head-to-head and that kind of thinking can just slow down innovation. That's point number one. We talked about ROI. I think it's important also to be very proactive in terms of defining the ROI, but also have a programmatic mindset to 5 to 10 years of a programmatic ROI calculus. Sometimes just sort of penalizing a solution without like we talked about ambient listening. If I'm just purely looking at visits, I might can the solution, but then I don't see all the hidden benefits that enable me to sort of enable the strategy in a much more broader way. So how am I sort of being much more articulate about the ROI drivers is important. And then third, and most important, I think, is that ultimately all of the adoption, healthcare has always had an adoption problem. Even in the IBM days, we had the technology of the solution, but it was not intuitive enough for adoption to scale. We should be really listening to the field, because the docs are very adept at knowing what's really transforming their operation. I hadn't anticipated ambient listening to have such a wide adoption so quickly. And so I think we need to be also signal amplifiers for seeing what the docs are doing and telling us back.
We're out of time, but very quickly, Greg and then Deepak. Greg, you first.
Yeah, I think right now AI is the wild, wild west, and there's a lot of players in the space. And so, sometimes different is always better, and really making sure that is it going to work for your organization and for your work processes. I think we're converging towards hopefully more kind of uniformed and able to universal conversational between the different platforms. But I would just say, make sure it's tried, true, and tested, and look how it would, look at how it's being used somewhere else and see is that working in your organization. Because there is a cost of implementation, and we also often see where 1 or 2 years it's there and you have to go somewhere else, and as well as the longevity of the organization. Is it a fly by night just popped up, or are they going to be around for 5 or 10 years, which is I think really what it's going to take to get this all working together.
Deepak.
Yeah, I would say don't adopt AI for the sake of AI, because if you do, then you're getting into this world of a bottomless pit of investment with no return. I would say lean into the changes in your operating model. Every healthcare provider, every delivery system is experiencing this change, that healthcare that used to be contained within the walls of a delivery system has become much more heterogeneous. I think there's a lot of partnerships outside the walls of the delivery system. A lot of the financial risk that you're taking on involves patients who are getting care outside your delivery system and many other areas. So when you recognize that, when you recognize the change in the operating model and the inefficiencies that come with delivering care in that model, I think AI will naturally offer opportunities to kind of improve how you deliver care in those areas, and use those opportunities to identify where you use these tools. So.
Thank you all for listening.